transparency, or is there protection for those individuals? Are they worried? And what do you do with an outlier who just has a consistently less than ideal performance? How do you address that? Do you name them? Do you confidentially work with them? Is there anything that works to reduce the variation in your performance?
So I'll address the data transparency issue first. It's all transparent. There's no blinded data. So the report that we send out on a monthly basis for blood pressure control and for any other metrics is completely transparent. Anybody can look at so-and-so's data, so and it's comparative. So if I go back real fast, I know the picture's really small, but you can kind of see up on the top there where you have those bar charts. Those are either bar charts representing care centers or bar charts representing clinicians, and the names are right there. So there's no blinding of anything. And so you can imagine that when I go out to a particular region or care center to bring this data directly to them, they see their rates. And they have access to their patient level data, so they can see exactly who are bringing their scores down. So there's definitely some competition there. I think clinicians are naturally competitive in nature, and we want to leverage that to help improve healthcare. And then in terms of, for the low performers, there are definitely some interventions. I think we have great clinician champions. Our internal medicine department chair, Dr. Joy Barrett, has been a key partner in this whole journey. And so really talking about at every department meeting is also on their individual one-on-one dashboard that gets reviewed every month with their divisional vice president. So there's a lot of ways where this information is coming at them from different angles and different areas. Can I answer your question? Thank you.
Thank you very much for that. Our second presentation will now be from the Chief Medical Officer of the Mercy Medical Group. Ben Balatbat is the Chief CMO for Mercy Medical, where he's the lead physician for population health and quality initiatives. His two major initiatives, which I like, are Measure Up and Pressure Down campaign. That, I think, encapsulates everything that we're trying to do today. So I'm pleased to have Ben join us and present the data from the Mercy Medical Group, which is a service of Dignity Health. So I make sure I get that right. Thanks for coming back.
Yeah, thanks, Bill. Thank you for allowing me to present our data. I'm new to this role, but I've led this initiative for the past 4 years. So we started our journey in care transformation around 4 or 5 years ago when we decided to become patient-centered medical home recognized. So our 17 primary care sites are now level 3 PCMH recognized. We have 29 specialty sites. We have around 440 clinicians in our practice, 100 or so are primary care physicians and APCs. So what we decided to do when we embarked on this journey was really look at where we could have the greatest bang for our money, looking at our population, and clearly hypertension and diabetes would be what we decided to tackle. And we, being part of the American Medical Group Association, there were 2 national programs, which is the Measure Our Pressure Down and the Diabetes Together to Go program. So we essentially adopted the various campaign plans that were available to us. We were kind of late in the Measure Our Pressure Down game. We got involved maybe just in the last 6 months, but for the diabetes program, we were one of the early innovators with the program. And so this is our current population data. Our total population attributed to our primary care physicians is around 135,000 patients, of which around 31,000 are diabetics, almost 12,000 are hypertensive patients, almost 12,000 are diabetics. And when you look at our diabetic population, ones have hypertension, it's quite significant, almost 80%. And then when you further look at other subgroups, 1,000 plus of our diabetics have congestive heart failure. Our current blood pressure control rate right now is hovering around 75%. A year ago, it was around 78%. I'll tell you why we're getting to an inertia and we're taking steps to intervene on that. So this was our baseline data when we embarked on the Together to Go campaign, and our blood pressure control rate at the time was 65%. And what's more notable at the time was we were not doing a good job even checking blood pressure in the clinics, mostly in our specialty departments. I remember when I joined Mercy around 10 years ago to our quality program, it was a debate on which vital signs to check and what the specialists were responsible for. And if there's specialists in the room, not in cardiology, but the dermatologists, the podiatrists said, well, we don't really want to check blood pressure because we don't want to deal with it. And so consequently, around 40% of the time, we were not even checking blood pressure. So when you look at this, so for meaningful use, we know blood pressure measurement is one of the metrics, and consistent enough, if it's a primary care physician, we check blood pressure 99% of the time, but for others, it was less. So this is an example of when we embarked, just doing some chart review, you see there was so much inertia, just like Dr. Bommer was talking about. We just left blood pressure uncontrolled, and this patient is a walking time bomb, literally, about ready to have a stroke with those blood pressure readings.
Can you just read what they are since they can't see it?
Yeah, so as you could see, this was like in November of 2014. The patient's blood pressure was 219/96. The patient came back like 6 days later. It was 175/80. It continued to be over 200, and in June of 15, you could see it was still 230/97. This is clearly not acceptable blood pressure readings, but it does happen, and if you're in the previous slide, that happens. It's not a significant finding. It happens less than 1% of the time, but that 1% can have significant adverse outcomes. So what we decided was to adopt this campaign planks. As already mentioned by Annie, is we look at how we can train our staff, educate them on proper blood pressure monitoring. We got automated cuffs because it decreased the variability. We discussed the guidelines. Our cardiologists gave talks, and again, we're measured on 140/90, but our mantra to our doctors and staff is we shoot for blood pressure of 130/80. And the idea is that it's addressed at every visit and also with cardiology, and we want people to intervene sooner and engage patients. And we do have a registry to track these patients. So one of the first things we did is really focus on training our staff. Patients come, they just had a large double espresso cup of coffee, the blood pressure stuff, and sometimes you observe them, they're chatting with the MA as their blood pressure is being taken, their feet are not really planted in the ground. So there was a lot of things that we trained our staff at the time. And we also had educational materials. They had to do an online training to check for their proficiency. And one of the big steps we decided to do then is let's engage all of the specialists. And so for us to be able to engage the specialists, we needed to give them the tools to do it. So what you see here is what's already been mentioned on the previous, by the previous speakers, is that it's important to let the patient rest for 5 minutes and check the blood pressure. And we categorize it into 3 levels. If it's above 140, but just at the early stage, is we push for earlier follow-up with primary care physicians, and there's a communication even before the patient left the office. And this can be done by any clinical staff. Then at the second level, we asked that they call the primary care physician's office to get for advice and get them seen much sooner. And for those, like the example I had on the screen, if it's over 210, we treat this as urgent, and the communication has to be physician to physician. So it was interesting because at the time, dermatology was not even checking blood pressure. They had like a 95% no blood pressure reading. And so we engaged physician champions, as you mentioned. So one of our dermatologists who is good with EMR and templates was the one who even built these templates that was easy for us to communicate with each other. And so as you could see, this is our data over the last couple of years. As the blood pressure no reading rate went down, our blood pressure reading also started going up. So this is our baseline data. As I mentioned, look at dermatology. It was 95% no blood pressure reading, orthopedic surgery 22%, ENT 50%. Our surgeons were not very good at it, 78%. But if you look over time, we have consistently decreased the no blood pressure reading, except for neurosurgery. Pediatrics, there's many reasons why they really shouldn't be part of this, but they're not included in the population we're tracking. So you had mentioned the importance of transparency, and this is our performance in the Department of Internal Medicine. I can tell you who those doctors are, but for reasons of this talk, I decided not to show them here. Just like with Sutter, we published this data. Everybody can see how everybody is performing, not just with diabetes, hypertension, but also with preventive metrics. And doctors are by nature very competitive, so this usually works, and there's also incentives tied to good performance. So this is our Together to Go metric. Where we have seen the greatest improvement was in the bundle score, where when you look at hemoglobin A1C less than 8, blood pressure control, nephropathy screening, and lipid management, we went from like 25% when we started to like 40% by the end of last year. And in fact, among all large medical groups, the first 2 years of the program, we were recognized as the one who had the greatest improvement in that metric. Blood pressure is still a work in progress. Diabetic control is fairly good. So I shared this vignette from one of our doctors because I think it showed how far we've gone from 9 years ago when it was a struggle to get our specialists to even check blood pressure. And I saw this in our newsletter 2 months ago, and I thought it was very fitting to illustrate how we get buy-in from our doctors. So Dr. Balatbat, who's been one of our champions, invariably, we will see him in our floor. He'll come down and say, Ben, you know, this patient had high blood pressure or was bradycardic. And many times, for patients who are fairly asymptomatic, we'll see various degrees of AV block that require intervention. So in this particular case, he was just highlighting how grateful he was that we now have these policies to require our doctors and staff to check blood pressure all the time, because it does definitely make a difference. This is just one example of the improved communication and outcomes among our doctors. So we're facing a major challenge right now. It's a perfect time to be the new CMO of the group, because we decided to implement a new electronic medical records 2 months ago, exactly 2 months ago today. And so it's a challenge, whereas we have optimized our previous electronic medical records, where we built in the cardiovascular risk score to allow the doctors to risk stratify and use it as a guide to intervene. We're starting from scratch right now, and as we're doing that, you deal with more inertia. People are busy with other things. So we just talked about this last Friday in our quality committee on how we really need to refocus our efforts and re-engage our specialists. We continue to work on decreasing the variability in performance, and we have advanced practice pharmacists now that are helping us track these patients for diabetic management and also for hypertension. So I think it's been good. I mean, there's outcomes that we show similar to what you saw with the efforts in Sutter. And the idea is really, as we continue to do this, is really the number of lives we can have a decrease in major adverse cardiovascular events, I think, will pay off. And when we have the data, we'll see that. So thank you for allowing me to show our efforts to you.
Questions here.
So while you're up there, that's fine too. Do you see each of you significant challenges if we adopt a lower threshold from 140 now going to 130. Are clinicians and patients going to accept that, or are they going to say, oh, come on, we just went through this for 140, now you're changing the laws or the rules, and now much harder to meet those new goals?
Yeah. So I think that's really the question, because the public is being educated in this, so they sometimes come prepared when they see us or we push to them. So you get two kinds of response. Those that, even though they need to be treated, they're adamant about it. So that's a challenge. But showing, what we find useful is looking how changing the numbers on the cardiovascular risk. Because if you say, okay, if you get your blood pressure to 120 over 80, you decrease your lipids, your cardiovascular risk drops. We find that as an effective tool in engaging our patients. For our doctors, it's really trying to get our patient, engaging their patients to come back sooner for follow-up has been more effective. But I think educating the public is key. Not so much necessarily, like you pointed out in your guidelines, about going on medications, but really much more aggressive lifestyle changes.
Any challenges to 130 over 80?
Yeah, I think so. I think the trick is going to be how we communicate that information and making sure that, I think our providers all know that, if you have a patient that meets certain criteria, it's always the clinical judgment in terms of what target, what we may measure at 140 over 90 or 150 over 90 on our measurement, but that doesn't include our clinicians to treating to lower targets. I think as we get ready to roll out our brand new hypertension guideline for Sutter Health that was spearheaded, we're going to be really getting that message home that is evidence-based and getting that communication, and then also sharing patient stories around that. The stories that you just shared, we certainly encounter many of those stories throughout as we improve our patients' blood pressure. So really sharing evidence-based information, criteria, and the stories around how improving their lives.
Can I just make a quick comment about that?
Yep.
Dr. Kim Buss. My name's Dr. Buss. And I work really closely with Annie, and I'm the medical director along with Susan Marks, who's the operations director for our telephonic disease management program. And we directly reach out to people who who have 3 elevated blood pressures in a row. So if you have 3 elevated blood pressures in a row, it automatically drops into our queue, our work list. What we did is create a new hypertension guideline that's Sutter Health system-wide that does have 130 over 80 as the new target for patients, and it does teach you how to individualize that. And so what we've been really thinking about is how our extended care team managers can help message that to providers by talking to the patient about what the benefits are for them potentially of a goal, what the American Heart Association target would be for them, and then kind of gently messaging back that to the providers in a way that still feels like the provider has a locus of control. So we think that's going to be tricky, but we think it's going to be a helpful way to help spread. Can I ask a second question?
Sure, you can ask a second question.
So I really wanted to ask a question, and I think this is the perfect time to ask, which is one of the things that I've learned, and I think Annie and both of you really illustrated that, is doctors get really competitive when it comes to blood pressure control. And so we've been able to just get huge alignment about reaching blood pressure control rates, like a control rate of 80. I mean, everyone's behind it. The whole world is our health is behind it. But changing a target to 130 over 80 feels completely removed from that. What? 130 over 80? Why bother? It's 140 over 90 that's going to get us to the 80, and we get the bottle of wine and the celebration, and the whole world starts joining, and our name shows up there at the top of the list, and now all of a sudden we're the hero. And what I have heard somebody once say is that you kind of have a distribution curve for blood pressure, and if you lower the goal, and everybody's treating blood pressure a little bit more assertively, because now people are moving the target to 130 over 80, that you're actually going to have a natural improvement of the control rate. And so I've been thinking that might be a really nice way to message it to doctors. That if we take a target of 130 over 80, and you're not always going to achieve it, and you're not always going to do it for every patient, but doing that is
So the control rate to 140, or the, well, yeah. I mean, if you bring people down in general, you'll have more that slip under 140.
I think that is something we need to be telling people, because our doctors are like racing to a finish line and they're super thrilled. And if we message that lowering the target a little bit will help us reach that goal, because, you know, yeah, some of those, I mean, you don't have, some of those people who are now hitting 130 over 80, there's going to be variation, and it's going to be more likely when they do pop in to get their blood pressure checked that it is going to be less than 140 or 90. But I don't know, I mean, I haven't had anybody say that that is the case. It's not entirely intuitive.
I just want to add to what Dr. Bommer said, which is in our first pilot community in San Diego, where one of our 3 targets was LDL 100, our cardiology co-chair from the University of California for that community, Dr. Anthony DeMaria, was driving the LDL target less than 70 with a very strong, so exactly what you're saying, and what we were just published for in Health Affairs is reducing acute myocardial infarctions, hospitalizations by 24%, sustained at 22% over 4 and 6 years. So I do think having a more of a stretch target makes people feel, you know, more comfortable.
When it seems like a stretch target of 130 over 80 just means that your distribution is going to go down, and you're going to, that cut point of 140 over 90 is going to be even better. I would love to see some statistics that support that so that we can use it when
I haven't seen them.
I've heard somebody else describe it once, and I haven't been able to go back and find that again. So thank you.
We have the Heart Association who's trying to get in here.
Yes, go ahead.
So my colleagues, my Gonzalez and they are also here. But I think, you know, I just jumped in, but we have seen, you know, obviously wanting to be respectful of the clinics up and or healthcare systems that partner with us, but we have seen, because we have made a conscientious effort this last year to really get our, you know, clinics that are part of our recognition program and our healthcare systems ready for this change. And so what we looked at is we told them last year, look at 140 over 90 and then 130 or 80. So we started to get it. We've
Don and Gary,
seen it go down.
Be sure to fill these out and leave them? Thank you. We need everybody to do their CME forms, please. Sorry to interrupt. Go ahead.
We've seen it go down, but we've seen it pop back up. So we have data that we will be sharing over this next year that will show exactly to your point. But we do work with some of the larger health systems. And it's not just within the Western states.
So as they are more aggressive, the control rate improves.
Yes, over the long term, we have
Yeah.
That's a really important message for us to share.
Right.
Doctor, would you say your name, please?
Sure. My name is Karthik Ramani. I'm a nephrologist and I'm part of SIP. Thank you. A couple of questions and comments. The first question to Dr. Bommer. Love your talk in sprint. Love the umbrella.
This is amazing.
But I think that it is not a one umbrella fit all kind of policy. And I think it also depends on the weather system.
Right.
So if
it's adjustable.
Hail,
It's
I don't think that
adjustable.
umbrella is going to hold. So in similar fashion, I think that sprint has a lot of exclusion criteria, especially with diabetics, excluding diabetics and those with end-stage renal disease and chronic kidney disease, as well as, I don't know whether it's a class effect on the medications that the patients were on, which is giving them benefit. So it's maybe not a number that all of us are looking to, but I think it's the patient, the class of medication, which is affecting that. So that was just a comment on the sprint guideline. So I think a 130/80 across the board may not be the right thing to do, but I think that that's something which has to be evaluated in the future and tailored to the population. And hopefully, things like pharmacogenomics and things like more precision medicine will come to that. A couple of comments on having a team-based approach to healthcare and using EMR systems. Number one is, I mean, if I check a blood pressure in a patient of mine who has 150/90, and then I check him 5 minutes later in a non-ideal situation, it's 131/81, do I target the 130/80? Or do I say, hey, come back in the future and check your blood pressure at home, do ambulatory blood pressure management? And so when you say addressing, and this is primarily to Annie, when you say addressing the blood pressure situation, do you mean making sure addressing medication adherence? Do you mean addressing and obtaining information and data from the Rite Aid, CVS, Walgreens, all the other healthcare systems where they are checking blood pressure. So maybe having a more team-based approach which involves local pharmacies and patients themselves is important in that ingredients of success. And so those are just a few comments of mine, and I'd like to open it up for further discussion later.
Well, I'm totally from the community, and I guess I'm a consumer, so I probably don't fit. I hope I do. But
we are happy you're here. Could you just tell us your name,
yeah,
please?
I'm Toni Cohen-Perry, and I'm a consultant at Yester College. We have a program for African American women's health legacy, and so we're constantly focusing on health management. And so the thing that I really would have liked to have a clear idea of what your definition for community participation, because I think with it, I recently resigned from a position as a director over gym. So I think gyms, senior centers, and nurse-run clinics, and places like that where you can have some messaging so you can get a broader partnership. We're always looking for pharmacies to donate high blood pressure cups and other things to help get, we want to know do people have a blood pressure cup at home and do they use it? And I think a broader definition might be helpful, because then it kind of opens up everybody to understand what your overall goal. But I have to say, this was a good investment of my hours. I really learned a lot, and I'm really one of those people that go to 150, 160. I just hit 61, so I tend to be there, so I was curious. So I appreciate hearing how you're thinking about it collectively, and I just want to say kudos, but I'd like to see a broader definition. I think that would help me.
So I think that's a great question, and my last question to the programs was going to be, we talked about what an institution or a healthcare system can do to enhance the patient-physician or healthcare provider relationship. The next question, or the bigger circle out there, is what can the community do to help the programs at Sutter, Mercy, Kaiser, and the others to do that? CDPH is here. They're definitely interested in seeing how they can facilitate as a community the performance of programs with healthcare systems here. So maybe we could ask Annie and then Ben if he's still here.
Ben had to leave for a meeting, sorry.
What could we offer? What could you use from the community, knowing that you have various organizations in the community, healthcare-oriented communications, ACC, AHA, you have the California Department of Public Health, all sitting here waiting to see how could they help you and what would be most helpful to your program?
That's a great question. I think one of the things that I know we don't do well across the board is really the connection to community resources for our patients in multiple frameworks, right? Not just patients who have hypertension, but really trying to understand better how we as a healthcare system and our care centers with our providers and our care center staff, how can we help connect those our patients to the right resources for different things? Is there a support group? Are there additional kind of dietary counseling resources? Are there other things that the patient with their conditions could really benefit from? And that connection of resources, I think, is a gap in our organization.
I have a list.
What?
Widespread advertising campaign about hypertension and the new numbers and why it matters and why it'll help you be alive to see your grandkids. Blood pressure cuff rental programs, blood pressure cuff giveaway programs, lobbying with all the quality measures so that home blood pressures or blood pressures that aren't taken at a visit that's charged for can still be counted, so that we're not filling up doctors' offices to get blood pressures taken that they don't need to have taken in a blood pressure, other than to make the quality standards. And of course, all the things that Andy said as well. But
I just wish you would have said it earlier in the program so that we could have gotten Mercy involved too, and Kaiser, who both left the room. But that's exactly what needs to happen. And the California Department of Public Health and our RightCare volunteer, Leslie Cummings, are trying to work up such a program, but they need to partner with the health systems to make it happen.
Like every fourth billboard is about hypertension and blood pressure. This is one we can solve.